this computer, go. Okay, so I'm going to show a few chest cases. First one is actually number 2. So this patient, you can see she has a large pleural effusion. She presented with progressive shortness of breath. And she has this kind of lobulated, infiltrative, enhancing chest mass. It's encasing her great vessels. It was causing narrowing of her SVC. Any thoughts? I can't see the chat box anymore, so please, Nellie, let me know what people are saying. Are you guys?
Lymphoma, teratoma, of course, all the T's. Thymoma.
Yeah, so there's the 4 T's, which is thymoma, terrible lymphoma, teratoma, and thyroid, like a goiter. So often you have to actually do a biopsy to diagnose this. We did a biopsy, and in this case, this was a lymphoma. And I'm just going to show the PET here, just to show you. It was very, very avid. So this got a DeVille score, which is what they do for PET when you're looking at lymphoma. And I'll show you a PowerPoint slide about the DeVille score later, but basically it compares the lymphadenopathy or the mass to the background liver and to the mediastinum. In this case, it was very avid. So that was a case of a lymphoma. This is a companion case. So all 4 of my cases are mediastinal masses. In this case, you can see that the patient is pregnant. So they did a non-contrast MRI. And in the corner of the film, we could see that there was this mediastinal mass. So on the coronals, we actually get a lot more of the field of view, and we could see that there was a fairly well encapsulated mediastinal mass. Had a couple of cystic spaces here. We didn't know what this was. We ended up doing a biopsy of this, and it came back thymic tissue. They couldn't really tell based on just our biopsies if this was a thymoma, an invasive thymoma, or a thymic carcinoma. She ended up, going to term for her pregnancy and getting a certain amount of chemo, and then afterwards got this resected and got postoperative radiation. When it was resected, this came back thymoma, but it also had a small invasive component. It's often very difficult to tell if a thymoma is just a bland thymoma or an invasive one, but this one was an invasive thymoma. So they usually can't be fully diagnosed until resection. Okay, my 3rd companion case is this one. This patient, you can see, had some masses in their upper mediastinum, and then this mass anterior to a brachiocephalic vein. And we thought this was basically lymphadenopathy. We were concerned about a head and neck cancer and decided that we wanted to biopsy this. We were kind of wondering, how are we going to biopsy this? But I always kind of give the patients benefit of the doubt, like, let's try repositioning when they come in, even if we don't look like we have a window here, because you can see the internal mammary vessels are right here. We've actually have to go quite a distance to get in. I'll show you the biopsy images. So one trick is that you can kind of like tape down the fat. So in order to kind of compress her breast, we taped it down, so that made it much smaller. And then we proceeded, and I'll just kind of cut to the chase here. So we do have a very small window right there between the sternum and the internal mammary vessels. And we were able to kind of get right through that window and get to the lesion.
Aarti,
yeah.
Have you considered doing transsternal biopsy?
Yes, and I'd love for you to talk about that. So I've done that a couple of times. If I see it even like, if I see a centimeter between, or I don't know, even if I see a window between the sternum and the vessels, I'd prefer to go that way. We have had some cases, the MSK people have helped us to go transsternal because my understanding is like you can kind of like buckle through if you go, if they're using like a biopsy drill. And if it's too close to the great vessels, that could be an issue. So I usually prefer, I even prefer to go through the lung rather than through the sternum. What's your preference?
I prefer to go through basically mediastinal fat, and I mean, a biopsy drill is very simple things to use. So, and
So in this case, like, would you rather have gone through the sternum and the fat here, or?
yeah. So other thing that I would always like to do is basically try to arrange my needle not going towards the great vessels, but rather towards the lung, because it's much easier to treat pneumothorax than rupture of the aorta or the
You might have
veins,
come in like
etc.
this way through
Yeah,
the bone, through the fat to the
yeah,
lesion. Okay.
exactly.
I often will use like spacers so that my throw is not going to be far. So I would use a very conservative throw here, like a 1 centimeter throw. But then you wouldn't get good cores. But
Right. And also the other component is, even though you're trying to use the spacer and you're trying to be very careful, etc., unfortunately, patients love to move and cough, and also all these big vessels, they move a lot just with basically pulsate. So sometimes there is more motion than you would expect. So yeah, I'd rather have a little bit more safety.
okay,
But
so
yeah.
transnaval and transsternal, call Ola. She'll fly
Yeah.
down from Boston. I'll just snake my way through next to some vessels. So anyway, this one came back normal thyroid tissue. So this was basically ectopic thyroid tissue, and there were other globules, I think, here of ectopic thyroid tissue in the mediastinum. So that was interesting. This was an interesting case.
Wow.
And then I have one
Velocity.
more case, which was very interesting. This was a young woman presented with facial swelling and had this mass. This looks very similar to the first one I showed you, and I would have said basically lymphoma until proven otherwise. It's pretty bland. It doesn't have that much enhancement. We did like 6 core biopsies here, and we basically didn't get a diagnosis. And I was very disappointed. And they said it was paucicellular, and it didn't look necrotic, so I was very confused about it. She ended up going for surgical biopsy and resection of this mass, and this actually came back as a desmoid tumor or fibromatosis. So I have just a couple of slides about these. So the cases I showed were lymphoma, and I'll go over the DeVille score in a second. A thymoma in that pregnant patient that also happened to have invasion, ectopic thyroid tissue, and fibromatosis, which is very rare. The 4 T's that we talked about are thymoma, terrible lymphoma, teratoma, and thyroid goiter. Thymoma is very much associated with myasthenia gravis, and you can't really tell the difference between a thymoma, an invasive thymoma, or carcinoma. The thymoma is more encapsulated, and as it gets more aggressive, it can develop calcification, necrosis, and even invasion. One thing that carcinoma loves to do is to have drop metastases to the pleura. So if you see that, it's unlikely to be lymphoma. This has more of a female predominance. Terrible lymphoma, these are more homogeneous, and in young patients, this can be Hodgkin's. Teratoma tends to be more in males, and especially if you see things with calcification and fat, think about that. And then if it's extending directly from a thyroid, think about a thyroid goiter. For lymphoma, they use PET CTs, they use this DeVille score. Basically, a 4 or 5 is positive, which means that the FDG uptake is greater than the liver. And they want it to kind of progress with treatment towards a 1 or 2. And finally, just one comment about desmoid tumors. This is fibromatosis. These are more common in the abdominal wall and in the mesentery, especially in patients with Gardner syndrome. You can also get them in the chest wall, very rare to get it in the mediastinum. And they're locally aggressive, so you want to beware of biopsying these and especially of resecting them because they can have a high rate of recurrence. So a lot of times now, if it's a smaller desmoid, maybe in the abdominal wall, they might even do watchful waiting. Anyway, this was a companion case from the literature. This was a 3-year-old boy. He had a mass coming out of his chest, huge mediastinal mass. You would have thought probably this is going to be a lymphoma or some bad teratoma, and this was actually all fibromatosis. You do worry that, trying to scrape these off the great vessels, there's going to be a high rate of recurrence because you're not going to be able to get necessarily all of the tissue. Any comments, questions?
I have a quick question. Maybe I missed and you talked about it, but how come they couldn't make this diagnosis with the 6 scores that you got?
Yeah, so fibromatosis or desmoid, which is the preferred term is fibromatosis. They can be very difficult to diagnose by FNA or core.
Okay.
Basically, it just looks like fibrosis. It can be very paucicellular. So it could
Right.
just kind of look like either debris or fibrosis. It's nothing specific about it. In the abdominal wall, if I know that
Fibrosis and can't infer
endometriosis
like
is in the differential, I'll put that in there and they'll test for like estrogen and progesterone. But sorry, what were you saying, Olga? Or somebody was?
I wasn't. I was
Oh.
mute.
Okay. Yeah, so it can be difficult to get it through FNA or core, especially because, yeah, lack of cells.
Thank you.
Any other questions? Okay, I'm going to stop the recording.